This is the lecture on articulations, the classification of joints. We classify joints in two different ways, structurally and functionally. Our three structural classes are fibrous, cartilaginous, and synovial. Our three functional classes are synarthrosis, which means non-movable, amphiarthrosis, slightly movable, and diarthrosis, which means freely movable. There are three kinds of fibrous joints, two kinds of cartilaginous joints, and several different kinds of synovial joints, and we're going to go through these one by one. So fibrous and cartilaginous joints can be either synarthrotic, remember that's immovable, or amphiarthrotic, which means slightly movable. All synovial joints are classified as diarthrotic. You have a picture in your textbook of different examples and diagrams of the joints. So fibrous joints are characterized by having just a thin layer of fibrous connective tissue connecting the two surfaces of the bone, which are really quite close to each other. So there's no space between them to speak of. And so there's very little, if any, movement. Sutures, syndesmoses, and gomphoses we're going to look at individually. All right, so on sutures, the very thin membrane that holds the bones together is called the sutural ligament. And it's really just a continuation of the periosteum of each bone over the surface of that sutural surface. Some of these, you remember from lab, will fuse completely into bone, forming what we call a synostosis. And so you remember from lab that the fetus has two frontal bones. They get fused together into a synostosis, and also the mandible does that. You studied fontanelles in lab, so I'm not real worried about that. I do want to talk to you about the kinds of sutures. So we're going to just look a little bit at the different categories of sutures. And what we're going to see here is that we have serrate sutures, which have a zigzaggy boundary between the bones. So you remember from lab your sagittal suture, the coronal suture, and the lambdoidal suture are all like that. That increases the surface area of contact between the bones, makes it very strong. It's immovable. The second kind is a squamosal suture, the squamous suture that you learn between the temporal bone, the bone's very thin there, and where it connects to the parietal bone. The two bones basically overlap. So that increases the surface area for a fibrous membrane to get between them. Again, immovable, pretty strong, but squamous means flat. The third kind of suture is not nearly as strong. It's a plane suture. This is as in a geometric plane, where you just have basically two flat surfaces that come in contact with each other with a very thin layer of fibrous membrane between them. And this applies to almost all of the smaller sutures of the skull. We didn't ask you to learn any of the names of them because the names for the most part are obvious. So the frontonasal suture is going to be the suture between the frontal bone and the nasal bone. I'm just waiting for it to exit from my drawing. Okay, so that's what you need to know about sutures, and you remember the sutures from lab. So the second kind is called a syndesmosis, and here what you see is this membrane, this interosseous membrane that kind of stitches the shaft of the radius and ulna to each other. That's actually a pretty wide gap, and so this is slightly movable. Remember, that means amphiarthrosis. And you're going to see that not only between the shafts of the radius and the ulna, but also between the shafts of the tibia and the fibula, where it's not nearly as broad and not nearly as movable. So you have very little movement between fibula and tibia, but a considerable amount of movement between radius and ulna, which allows you to pronate and supinate at the wrist. Okay, our next kind of fibrous joint, the last kind, is called a gomphosis. A gomphosis is a peg-like bone sitting in a socket, and that obviously applies to the roots of teeth. And here the membrane that holds the tooth root into the socket, the alveolus of the jawbone, is called the periodontal ligament, and those hold the teeth in place. So the periodontal ligament can become inflamed in periodontitis, leading to periodontal disease, and if they break down, then the tooth loses its hold and can actually come out. So, okay, cartilaginous joints. Cartilaginous joints use cartilage to hold the two bones together, and it depends on whether it's hyaline cartilage or fibrocartilage. A synchondrosis is composed of hyaline cartilage, and a symphysis is fibrocartilage. So synchondroses include temporary joints, which are seen in the embryonic, fetal, and juvenile skeleton. So even the cartilage within the os coxae or the cartilage of an epiphyseal plate are considered synchondroses. These are immovable joints. And of course, once the bone completely ossifies, that joint is replaced by synostosis. Some, like the costal cartilages, are pretty permanent. And those costal cartilages are actually going to develop a joint cavity between the cartilage and the sternum. But the longer pieces of cartilage really are kind of flexible, which makes them amphiarthroses. But the ones up like at the first true rib and maybe the second, those are pretty short pieces of cartilage, so they're not going to move much at all. And so those sternocostal cartilages are immovable, synostoses. Or excuse me, synchondroses. All right, so there you can see that the sternocostal joints are synchondroses. The symphyses are found, well, the pubic symphysis is named for that, so that's an obvious example. We have fibrocartilage here. You find a symphysis between the manubrium of the sternum and the body of the sternum, but most importantly to me are the intervertebral discs, because they're going to allow a little bit of movement as you bend over. Now, your backbone in total is pretty flexible, but each joint individually is only slightly movable. Okay, so here are some pictures of the different fibrocartilaginous joints. Next, finally, we get to our synovial joints. All synovial joints have a joint cavity called the synovial cavity. It's filled with fluid called synovial fluid. They're not big spaces. The bones fit very closely together, but the cavity indicates that they're not stitched tightly to each other. The bone surfaces are free to move. So it does give them more mobility, but it also makes the joints not as strong as, say, a suture would be. So we need to go back and look at those examples. So let's do that real quick. Okay, so here you can see, hang on, it's catching up. Here you can see the different kinds of synovial joints. You have gliding or plane joints. These are things like the joints between the tarsal bones and carpal bones, the joints between the rib and the vertebral body. Ball and socket, you know, is hip and shoulder. Hinge joints include things like elbows and interphalangeal joints. You only have one kind of saddle joint. It's associated with your thumb. The saddle joint is the joint between the metacarpus of the thumb and the first carpal that it interacts with. Condyloid joints, condyles are like knuckles. Okay, now you know condyles from lab. You learn mandibular condyle and occipital condyle and the condyles of the femur. And condyle is oval in its shape. And because it's oval, it can bend in two directions, okay? So it can spread out sideways or it can flex and extend. And then finally, pivot joints. Pivot joints have to rotate. So you have the head of the radius that can rotate, and you also have the joint between the atlas and the axis that can rotate. All right, back on track with characteristics of synovial joints. Okay, so what do we have in the structure of a joint? Well, you know that the bones have on their articular surface, they have articular cartilage, which is hyaline cartilage, provides a very smooth surface for the bones to glide against each other. The synovial cavity is simply the gap between the articular cartilages. There's a capsule. It's a joint capsule. It has an outer layer, the fibrous capsule, and an inner layer, the synovial membrane. That synovial membrane is a connective tissue membrane, and the tissue type officially is a loose connective tissue, but I'm going to tell you it looks a lot like an epithelium, and it secretes a fluid, the synovial fluid. So here you see a diagram of all the parts of a synovial membrane, and you'll find that there's some extra things in here. So if you look carefully, you'll see there is a bursa. A bursa is an extension of the joint cavity, and a tendon sheath, and both the bursa and the tendon sheath are lined by synovial membrane. So they're also going to have that slippery surface of synovial fluid, and they are adapted to reducing friction between the surfaces of the bone and the skin, or between tendons and ligaments, or whatever. So each bursa, or collectively the bursae, are little pockets of synovial membrane that extend away from the joint wherever there's more friction. You have like 3 of them associated with your knee. And if they get inflamed, that's called bursitis. Then, of course, you have tendons and ligaments to stabilize the joint. You have articular discs, which are little pads of fibrocartilage. Note the locations. Temporomandibular is your jaw joint. Sternoclavicular and acromioclavicular, that's just the opposite ends of the clavicle. So they're just little pads of fibrocartilage there. You might also have some in other places, like associated with your thumb. You might have a little articular disc. The articular discs in the knee are large and pretty substantial, and they have a special name. They're called the menisci. Singular is meniscus. And basically, they're just big articular discs. So again, they're made of fibrocartilage. And then remember, the tendon sheaths are little extensions of synovial membrane surrounding tendons that otherwise might create friction. So bursa can get inflamed and cause bursitis. Tendon sheaths can also get inflamed, and they cause what we call tenosynovitis. You might know it as carpal tunnel syndrome. Okay, so when we talk just about the synovial joints, remember these are freely movable ones. Some of them move only in one direction, like your elbow, you can only flex and extend. Some move in 2 directions, so like your wrist or your knuckles, you can flex and extend. You can also spread them out or turn them sideways, bend them sideways. That's called abduction and adduction. And then multi-axis means you can move around more than 1 or 2. So the ball and socket joints of the shoulder and hip can also pivot, and that makes them multi-axial. All right, so you have this diagram in your book that may or may not actually help you, but it gives you some examples of the different kinds. Okay, so here are the types of movements that go with those types of synovial joints. So you can have gliding movement at a plane joint. In gliding movement, the surfaces of the bones never lift off each other. They can slide against each other, and that's about it. Angular movements mean you're actually changing the angle between the 2 bones. So imagine bending at your elbow. You're making it a smaller angle. It's an acute angle. And then as you straighten it all the way out to straight, extended, then that's like a 180-degree angle. So that's what we mean by angular. Flexion and extension are bending and straightening. Hyperextension you can do if you can move a body part past its normal anatomical position, like bending your head back or pulling your arm back. Those are hyperextension. Plantar and dorsiflexion are bending at the ankle. Specifically, plantar flexion is pointing your toes. Abduction and adduction are what you do when you do jumping jacks. Our circular movements include rotation and pronation and supination and circumduction. Rotation is a movement that's allowed at a pivot joint, but also at a ball and socket joint. So you can rotate medially or laterally. Pronation and supination is that special movement of the forearm. It's actually a movement at the wrist. That's what you can see. But if you're doing that, you can feel the rotation at the head of your radius. The head of the radius is rotating against the 2 bones that it lies next to, the ulna and the humerus. And then circumduction is just like drawing a circle. All right, so you have these diagrams that will help you figure out flexion, extension. Notice the knee bends backwards. Hyperextension is going back beyond the normal anatomical position. Plantar and dorsiflexion abduction and adduction. Remember, abduct means to take away, adduct means to put it back. Here's our circular movements: rotation, pronation and supination, and circumduction. And then we have some other special movements which we see only in particular places. Personally, I put pronation and supination here. Elevation and depression means raising and lowering. You can do that with your jaw. So when you close your jaw, when you bite, you're elevating the jaw, and when you depress it, you're dropping it down. So you're opening your mouth. Protraction and retraction can be done with the clavicle and maybe your mandible. Excursion, I am definitely not worried about. Excursion means chewing your cud. Opposition and reposition is crossing the palm over the, crossing the thumb over the palm and then putting it back. And inversion and eversion, well, let's just look at the pictures. That will help. So there's elevation and depression of the shoulders. There is protraction and retraction of the jaw. Here's lateral excursion, opposition and reposition, and then inversion and eversion is moving the sole of the foot medially to invert it and laterally to evert it. Okay, so that was our quick tour. If we had this in class, we would be looking at these examples, and I would be asking you to analyze these movements. We're not going to be able to do that online. So I hope that this helped. Go through your standard practice quizzes, Learn Smart. I have a table for you in Canvas that you can fill out if you want, and just use the resources available to you and ask questions in class.